So, ladies and gentlemen, we're coming back to the subject of heart disease and thalassemia. Heart disease and thalassemia, as you know very well, is one of the most important complications that we do meet. And it is one that is preventable and treatable. And one of the pioneers in the study of heart disease and thalassemia is Professor Malcolm Walker of the University College London. He has been with us for a very long time and has in fact defined through his studies the monitoring process as well as the treatment process. So, Professor Walker, let me, it's time for you to take over.
Okay, thank you very much indeed. Thanks for the kind comments. Can you hear me okay? Is the sound appropriate?
Absolutely.
Okay, so yes, I work in central London and historically became involved in thalassemia because within our part of north central London was a very large community, mainly from Cyprus, but also from other parts of the world, from parts of the Middle East, Turkey, and increasingly London is a cosmopolitan world city. And so the number of patients has remained concentrated in certain areas, including our hospital. And I got involved via our local hematologists, including the now retired but very famous Dr. Beatrix Wonke, who initiated all this by referring me her patients who were having heart problems and heart failure. So that's very, very many years ago. I can't claim to have been in the old cruciform, that was a new University College Hospital, opened in 1906. And then I've been working more recently in this very modern hospital here in central London, still a very, very comfortable and nice place, but managed through various means to open my own separate institution within the University College area called the Hatter Cardiovascular Institute. I've got nothing to declare from this point of view, and let's go straight on. This is very early data, but it makes a point. I'm just going to move this aside a little. It makes a point. This is from Bernadette Medell, a very eminent epidemiologist, a doctor who looks after illnesses affecting society. And she was very much involved in thalassemia with an original cohort of here, as you see, just under 800 UK thalassemia major patients, making the point that if these patients received no blood, they did not survive childhood. And it was discovered, as you well know, once the disease was defined as a chronic anemia, that if you provide regular transfusions, then patients were certainly surviving 90% plus into their early teenage years. Sadly, what became clear was that at that point, again, if you did nothing else other than just transfuse, there was a very rapid decline, so that in this cohort, again, no one survived beyond the age of 25. And the majority of the deaths at this point are due to heart complications, and they are due to the accumulation of iron within the heart, because the human body cannot get rid of the excess iron that is produced when the transfused red blood cells are broken down. And this is a complex, but it's just making a point that this free form of iron that accumulates in the tissues can be reduced if you use drugs called chelators that bind the iron in the tissues and in the blood and enable the individual, the person, to excrete it in the urine and in the feces. But this labile iron, if it accumulates through excess blood transfusion, and in some thalassemics, particularly the intermediate population, through excessive absorption through the gut, you end up with what we call labile, non-bound iron, both within the blood and within cells. And this produces what we call reactive oxygen species. These are various compounds that have a lot of deleterious effects on cells throughout. I'll concentrate on the heart, and by various different ways of damaging things like mitochondria, causing some DNA damage, activating certain enzymes, you end up with injured cells that eventually don't survive. There's also a preponderance, or at least a propensity, to increased infection. For us in medicine, it's important to know some of these details because it allows us to have targets where we might try and try and improve the outcome. However, the most important thing to date has been the use of these drugs to reduce the amount of labile iron in the body. And this is an ultrasound of the heart called an echocardiogram, very simple test. Put a little probe on the front of the chest with a bit of jelly and you can see the heart. It is the same technology that is used routinely to look at pregnancies and to look at the baby inside the mother's womb. So here we have, and this is a patient who came into clinic some years ago now. She was at that stage 27 years of age, a young woman who really came in feeling a bit breathless and with a bit of ankle swelling, not much in the way, she wasn't much of a complaining sort of young woman. And she had been treated all her life with desferoxamine by injection, but she admitted at that stage that really she didn't like using this very much and used to miss out many days and weeks. And the consequence when she came to clinic was a heart that looks like this. This is the main pumping chamber, and these are the little valves here. But the main pumping chamber, even I think to a lay audience, you can see is not really doing very much, not contracting. And we use a number called the EF, or ejection fraction, to determine how well the pump's working. And a normal non-thalassemic person, it should be between 55 and 75. So clearly she's very, very severely compromised. Very early on, it was established that you can remove iron. And this is a paper that we did with Lisa Anderson, who's a research fellow working for myself and with my colleague Dudley Pennell. This is early work showing that in a group of patients with very severe iron overload and heart function that was reduced down at 50% or so, if you gave them intravenous desferoxamine, if you gave it to them by vein 24 hours a day, 7 days a week, over a 12-month period, the heart pumping capacity came up right bang into the normal range. This graph on the right shows the heart size. The heart, when she was unwell, when this group of patients were unwell, is big, and as the heart gets more efficient, it gets smaller in size. So this was early evidence directly, prospectively, looking at the heart and heart function and showing that if you use a chelator, that you can document a fall in the heart size and an improvement in the pump. And what does that look like to the patient? Well, here she is when she was presented, and here she is 14 months later. And you can see how well the heart is pumping. And, you know, from anybody looking at this would say, any cardiologist or expert, they will tell you that is a normal heart, and it is. So this to me was a very, very early wake-up call that these patients were unlike most of the patients that I come across in general cardiology who present with a cardiomyopathy, which is what this is called. Very few can you get to a situation where they are normal, not just better, but completely normal. And you can see here, if you want the number, the ejection fraction calculates to 63%. And that was because she had a combination of intravenous desferoxamine with the tablet deferriprone. And she did well, and she continues to do well, this young woman. She's alive and well today. One of the problems that we faced in the 1990s, that despite knowing that you had to transfuse these youngsters and then knowing that you had to introduce chelation, initially the only drug was the difficult to use parenteral medication deferoxamine. Later came the oral deferriprone. Despite having these, in my clinic, we were seeing patients presenting in heart failure, much as this young woman did. And up until the late 1990s, those of us who were looking after these patients were facing about 30% of these youngsters in their teens and early 20s were not surviving. That very, very shocking, both to the families, to colleagues, to all of us, is a terrible statistic. And once you get bad heart failure like this one, and you need admission to hospital, then overall, it's very difficult to help these patients. And about half, even in what you might call expert units, wouldn't survive. So therefore, it became very, very clear very early on that we needed a better method to detect people at risk before their function deteriorated so badly. We needed an early warning system. And that's where that same research fellow, Lisa Anderson, came into play. So between Dr. Pennell and myself, Dr. Pennell is an expert in imaging, and he had one of the early cardiac magnetic resonance units in London. And so we decided this is an obvious potential tool. And so I'm going to talk a little bit about the cardiac MRI scan. It's a principle of getting pictures with an MRI that you, with increasing what we call echo time, as you generate a picture, with increasing echo time, the picture degenerates and gets darker. This is a section through a liver. Beginning of the scan, it's light, and as the echo time increases, you end up with a dark liver. And the speed at which the signal decays, becomes darker, is a mathematical function called an exponential. If you have an exponential, you can derive a time constant, and that's what Lisa Anderson established. And I'm not going to concentrate too much on the rest, but just the T2 star describes how fast this curve decays. Now, one of the physical principles of magnetic resonance imaging is that the speed at which these curves decay are affected by the environment. So in particular, if you have iron in the tissue, that decay is very much faster. So the picture gets dark very much more quickly. And we were established fairly soon that it was reproducible, that actually, if you have a lot of iron, the technique gets into trouble. The other thing just to emphasize is that the lower the T2 star number, the more iron in the heart. The higher the number, the less iron. And for a normal population, we now think the T2 star is about 30-35 milliseconds. We were able to demonstrate that in the thalassemia population that there was a very distinct relationship between iron content in the tissues and the T2 star. Just a word, even in the lay population, there are different sorts of magnets. The ones that first came were what we'll call 1.5 T. That's the strength of the magnetic field, 1.5 Tesla. And all our data was made on 1.5 Tesla machines. There are now 3 Tesla machines, and many radiology departments are throwing out the 1.5 and replacing it with a 3T. That is a bit of a disaster for T2 star because you cannot measure it so reliably. We can go into that in discussion if needed. Using this technique, Lisa was able to show that iron was related to the T2 star. The other thing that we showed, that giving people treatment, in this case it was a trial that we did with our now deceased colleague Renzo Gallinello and Dudley Pennell and myself and others, that we showed that if you give people deferoxamine combined with the pill deferoprone, the ejection fraction rose quicker than it did on deferoxamine alone. And the heart T2 star increased, that is, there was less iron in the heart, mirrored the improvement in function. And over time, looking at series of patients, we were able to draw a dose response, if you like, so that in this series, that again, another research fellow with Dr. Pennell and myself, a chap called Paul Kirk, he demonstrated that if the T2 star in a thalassemic was 6 milliseconds or less in our country, in the UK, there was about a 50% chance that they'd go into heart failure within a year. If it was 6 to 10 milliseconds, then their risk was lower, just under 30%. And if it was over 20 milliseconds, none of that patient group developed heart failure in a year. So this shows that you could use the T2 star to gauge the risk of the individual. And the higher the T2 star, the less the risk. And that's really important if you're going to have to convince patients to take difficult treatments more regularly. So the dose response, the more iron, the lower the T2 star, the higher the risk. And the heart failure risk is about half within 12 months if the T2 star is less than 6. And this led to this phenomenon. Again, this is the UK cohort that was being followed by Bernadette Medel. And this was really the number of deaths in our cohort across these periods of time. In red, mostly were deaths associated with heart iron accumulation. And you'll see that between 1999 and 2003, there was a massive reduction in deaths. And there were no new TILs, no new tablets, no new nothing, except we as the doctors, the hematologists, myself and others, those of us looking after the patients, now were able to direct our therapy to the patients who are most risk. And Bernadette Medel, and here she is, still very active these days, essentially summarized this by saying the more than 70% reduction in mortality, mainly due to heart iron overload, can be attributed to the introduction of the MRI T2 star and to the being able to use a number of the oral iron chelators. So having the drugs, but most importantly, to apply them to the right person at the right dose and to be able to monitor how effective you were being was for the first time available to us with the T2 star, and ended up with a survival benefit. And you can summarize now there are different techniques. Bear in mind that the black blood makes it for better curve fitting. So we tend to go for what we call black blood T2 star. And we tend to look at the wall between the two ventricles, the interventricular septum. Take home messages. The T2 star over 20 milliseconds is conventionally called normal. Things are moving on a little bit. We might come to that. It's now probably, I think we can say that we've changed the goalpost to somewhere between 26 and 28 being normal. I think 20 includes quite a lot of people that may be at a small degree of risk. The other thing to bear in mind, when you don't have much iron in the heart, a 6 millisecond change in the T2 star, let's say from 30 to 36, is really, there's very little real change in how much iron has left. However, if you have a lot of iron in your heart, a change from 6 milliseconds to 12 milliseconds halves the amount of iron in your heart. So the only reason for emphasizing this is that people get very fixated, particularly patients and their relatives. Oh, the T2 star's gone from 32 to 34, this is bad news, or from 34 to 32, I should say, that's bad news. No, that is just a little bit of noise. However, movement at these low T2 stars are very, very important and tell us what's happening to the heart. So in terms, I'm just going to concentrate a little bit on the chelators that we have available. There are 3 in general use, and a group of us, these are mostly heart doctors with hematologists as well, published, this is the main international journal circulation for cardiovascular disease and cardiovascular research. And we produced a summary paper pointing out how best to treat thalassaemia major to protect the heart. And we came across a couple of conclusions, which I'm not going to burden you with everything, but all 3 chelators can work if you give them at the right doses and if the patient is able to take them. And the beauty of having more than one chelator is that you can adjust therapy to the individual's requirements. So if we look at what happens, these are the 3 chelators: deferriprone, deferasirox, and deferoxamine. And here, this is from an Italian, fairly recently published, an Italian cohort. And you can see here, the global T2 star goes up with each of the chelators. These are people taking just one chelator at a time, so-called monotherapy. And you can see that everybody gets an improvement, and this is statistically significant for the deferriprone, deferasirox, and for the deferoxamine injections. When we look at heart function with the ejection fraction, it improves a little with deferriprone, less obviously with deferasirox, improves a little bit with deferoxamine. And what happens on the left ventricle happens on the right ventricle. So they work. And what became clear also from the publication I showed you a bit earlier that we did with Renzo Gallinello is that if you combine chelators, you improve the amount and the speed at which iron is removed from the tissues. So you've got here a couple of summaries. So daily deferriprone plus deferoxamine can reverse cardiac siderosis and improve left ventricular ejection fraction, and it's a well-established therapy. A little as 2 daily doses of deferoxamine added to monotherapy with deferriprone can improve iron balance, and combinations of deferasirox, Exjade in Europe, and deferriprone have been approved by European medicine agencies and are, from my recent experience from doing a study in India, are actually a very well tolerated and a good form of treatment. There are a number of guidelines, and they all look very similar. The USA, as perhaps usual, is a little bit out on the limb, but we won't go into that. That's not really relevant today. Now, I was asked also to just speculate a little bit on futures, and I will do that now in the last few slides. There are things that have changed. One of the issues with MRI is it historically and classically, if you follow the standard protocols, takes quite a long time, anything from 45 to 55 minutes in the magnet. And it's an expensive machine, and an hour in the magnet is a very expensive resource. So even in rich countries, relatively rich countries like the UK, and myself, I was very much rationed to the number of MRI scans I could do. With my colleague James Moon and others, we've been exploring ways to try and increase the availability and accessibility of MRI, because it still remains a gold standard to measure the risk, i.e. measure the iron content. And these are very pretty pictures. The beauty of them is that you don't need to do any curve fitting, that they are interpreting and putting a color coding on the global signal from the heart. This bit here is the left ventricle, this donut. And from principles of physics, this heart here in green has no iron. This one with a lot of iron is blue. And the beauty of this is with this T1 mapping technique is that you're able to do almost like a Polaroid photograph. It's instant. Patient's in there, scan is done, bang, this comes up on the screen. So we thought this was a useful technique. In order to prove it in the field, we took a series of people, again, published in Circulation a little while ago now. We went to Thailand and worked with our colleagues in Thailand to screen their patients. And we showed that you could do MRIs and they were diagnostic in terms of iron. So we did 120 MRIs in 2 days' work. The average scan was less than 10 minutes, including the analysis. So now you get into a true screening capacity. You can collect your patients together and you can push them through, get their risk established very early on, particularly important in developing nations where patients may be living long distances away, access to MRI is expensive and difficult. So we showed that you could do that with an average scan time. The average for the whole study was less than 8 minutes. And we showed, because we also measure for T2 star, this T1 map was completely consistent with T2 star. So we think we're measuring the same thing in a slightly different way. I took this more recently to India because all very well taking pretty pictures, but you have to try and detect whether that makes any difference to patient outcomes. This data is not yet published. I've only just in the last few weeks finished the whole of the analysis. So 104 patients in 2 centers in India. We had to use, because that's all they had, very elderly scanners. So therefore we didn't use this modern T1 mapping. We used T2 stars and we looked at heart function. And we managed 12 minutes in these old machines, which is pretty good. And we used, the patients would come in, have their scan, then they would see myself or one of my colleagues, and we would then recommend what needs to be done. Are they at risk or are they safe? This is one of the groups. They know their photographs appearing. This is one of the groups in one of the centers. And then having done the first scan, we went back 14 months later and did a second scan to see if there'd been any change in the patient's situation. Firstly, I'd have to say, was there any cardiac load? Any iron, about 36% of patients in one center had iron, fewer in the other center. Severe iron overload, less than 10, it was 15, is more equal. So this is important because you could then see what the centers are doing differently that might improve matters. Where liver was concerned, there was a lot, 40% nearly in both centers with a lot of liver iron. And what I was able to demonstrate there is that we had about 53% of those patients that we screened over this weekend, 104 patients, over half needed some change in their treatment. The green here is that we strongly recommended combination treatment. So about 40%, about half were doing reasonably well. And so we showed that it was practical. You could do it in a patient camp, 104 patients over 2 days, and you got results that you could then use to help manage the patients. I will tell you, because I have analyzed the data and I'm about to put it out to publication, between the first and second scanning, there was an improvement both in heart function and T2 stars. So something happened at that weekend, and it looks to be for the good. Couple of brief words. ECGs we do. Here again, this is part of the same camp, doing little ECGs in the field. ECGs don't give us a huge amount of information, but we do them. They're helpful in some respects in following individuals. Monitoring the heart over longer periods, increasingly important as the thalassaemic population ages. This is one of these stick-on 14-day patches in one of our patients who had had intermittent symptoms. On day 9 and 10, we wouldn't have picked this up any other way. He suddenly has a rise. This is the heart rate summary here. He suddenly has a rise in heart, which when we look at it is atrial fibrillation. So it only happened for about 4 or 5 hours, maybe 6 hours during the night on between day 9 and 10. There is no other way that we would have picked this up. And atrial fibrillation in the thalassemia population is a very important issue. I'm going to rush through that. Nowadays, there are other ways you can try and monitor your patients. Everybody's got a phone. The little cardia device can provide very diagnostic quality ECGs for people with symptoms. And now, of course, even the Apple II watch. And there are others in the market. A few words on the echo, useful tool. You saw how I was able to use it in my clinic. Although ejection fraction is historically used, there are better measures because the ejection fraction is late. Once that's changing, that patient is in a lot of trouble. And the normal ejection fraction for the thalassemia population is over 60%. And any fall of 10% should be followed by some kind of action. I'm just going to rush through these, they're not particularly relevant to you. There are new measures which are less intuitive, something called global longitudinal strain, and that's proving to be helpful. Here, this is a group from Hong Kong showing that looking at strain in people who otherwise have normal hearts, that the those that have normal strain do better compared to those who have abnormal strain. So again, there are tools to make earlier diagnoses, to detect if someone is not doing so well, and to be able to then take some kind of remedial action. So I think it can be summary, we can say that there's been a huge and documented improvement in the outlook for thalassemia patients, that using MRI scans improve the precision of diagnosing heart risk, and the faster sequences hold the promise of increasing availability. So to give you an idea, the cost, this is rough and ready, but the overall cost of the MR scan that we did for our study was about $69 US. Many of the patients that I saw, only a third had ever had an MRI before, but many of them paid up to $600 for their MRI. So conventional diagnostic tools, if you use them properly, can also add some important information so you can detect problems before they cause symptoms. And so the improved outlook is related to better treatment with using selections of chelators, and most importantly, I think, combination therapy. And there are new challenges as our population ages. Our mean age in our clinic, I think, is over 46 or something. So atrial fibrillation, something called heart failure with preserved ejection fraction, and pulmonary hypertension all require surveillance, screening, and early intervention should you detect those trends. And then here, the little cartoon, as people get older, you've got to prevent them going into the, if I may say, between friends, the Trump phenotype. We need to avoid that progression. So at that point, I will stop, and I'd be very happy to take questions should any arise.
Thank you, Professor Walker, for your time and for this presentation. I have 3 questions here. Let me switch on. The first one, can it be concluded or assumed that a person with iron deposits in heart must be having high deposits of iron in the liver for sure?
No, it's not that simple. Overall, that is true, but there are some notable individuals who, and this is why we, historically, as you know, we used to use the liver as our benchmark and assume what happened in the liver happened in the heart. And we had a number of very catastrophic outcomes from making that assumption. And so there can be situations with people with significant iron in the heart and none in the liver. It sort of depends on the time that you are seeing them during therapy, because the trajectory, if you like, is different for the 2 tissues, so that iron can be removed much more rapidly from the liver than from the heart. So you can have the scenario where someone goes on to enhanced treatment, the liver clears, but the heart has not. So there you end up with someone whose liver is fine, but they have a lot in the heart. So yes, you cannot rely, you need to have organ specificity for your selection of risk.
Okay. The next question, the person says, I have hemoglobin E beta thalassemia, transfusion dependent. I transfuse every 3 weeks. My hemoglobin is always 10. Recently, I was diagnosed with pulmonary hypertension. From what I know, pulmonary hypertension mostly happened among non-transfusion dependent thalassemia patients, not on the transfusion dependent thalassemia patient. Can you explain more about this?
Well, that would be unusual, but not unknown. So the first thing would be to be very certain there's not an alternative cause. And the alternative, particularly in someone who may have had a splenectomy, might be chronic pulmonary thromboembolism. So you would look very carefully whether there was any evidence whatsoever of pulmonary thromboembolic disease. So you're right, historically, it used to be said, and it still is the case, that non-transfused thalassemia intermedia have the much higher incidence of pulmonary hypertension than the transfused E-betas or Thal majors. But we do see a smattering even in our thalassemia major, even in those that have actually been transfused. Some of that relates to significant amounts of intravascular hemolysis. Some people who have hemolytic reactions and things like that may be more susceptible, we're not certain. I would be very careful to exclude any problems of the left ventricle. As we age, the left ventricle gets stiffer, and that might require its own treatment. So it needs careful, number one, make no assumptions, two, look for remediable causes, and then, if necessary, treat the pulmonary hypertension itself.
Okay, thank you. Next question, which is the best way to reduce heart iron with desferrioxamine, whether through vein or subcutaneous method?
What's most important is to take it, and the delivery method is less important than the constancy of treatment. So what appears to be important is for there to be some chelator in the bloodstream almost all the time. The trouble with deferoxamine on its own, taking it 7 days a week, is a monumental effort and challenge for the patient. It's a difficult thing to do, which is why in virtually every scenario, combination or adding in or using oral therapy as well as sometimes with deferoxamine appears to produce better and quicker results. The difficulty appears to be in the periods when you don't have chelator in the bloodstream, there is a reversal of all the chelation that you manage to, the de-ironing that you manage to achieve. So, you know, sadly, it's having some desferal in the bloodstream 24/7 is the best, but very difficult to achieve.
Yeah. And another question, I'm a Thal major patient, T2 star MRI is 11, liver MRI is severely less than 1, 2D echo is normal, patients is on a regular chelation on deferrisorox and deferoproin. Patient feels breathless on hemoglobin of 10. Can we do the multi-gated acquisition scan or cardiac MRI for diagnosis of early cardiac issues? Ferritin is around 3,000. LVEF is 58.
So I think you've got all the information. There is iron in both tissues, and breathlessness, I'm not too sure. It's difficult to explain that fully on the function you've explained. You know, I'm not sure, you know, that more imaging is going to get you any further forward. I think what has to be done is to have some method, something in order to try and improve the ferritin, which will then give you an index that the tissue loading has also improved. But it's going to be slow. It's reassuring that function is normal, and the number of people that develop cardiac failure or cardiac function with a T2 star of 11 is relatively small. The risk is relatively low, but one mustn't be complacent. So I think it's just, I'm afraid, carrying on, missing out as little as possible with the aim to get both liver and heart iron into the normal ranges. Interestingly, this is a very common finding in our group in India on the first scan, And lo and behold, by the second scan, they'd improved, you know, and a lot of them without any, what they say, oh no, I didn't change anything. Well, obviously they had changed something. One of the things they changed is probably taking their medication more often, having fewer spells without treatment.
Okay, thank you. And another question is, I'm a E-beta thalassemia patient. My blood transfusion has been stopped for 7 years. I'm taking Rasirox for iron chelation, which label iron is 1900. My question is, could COVID-19 be any problem on me for E-beta thalassemia patient?
Don't know, thankfully.
Okay.
I don't know. You know, I don't know how old you are, which would be more pertinent, how slim you are, which would be more pertinent, whether you have any other comorbidities. In my spirit, but I think my colleagues in Nicosia might be better able to answer this from the general view of the population at large, whether there's any signal that thalassemia patients do any worse. My own very local experience is that there isn't that signal from here, but most of our patients are being incredibly careful, which I think is the right thing to do. But at the moment, I don't think you consider yourself to be especially vulnerable.
Okay. And
yes, I think we should comment on Professor Walker's that this is true. This is our observations at TIF, that the group, the thalassemia patients, do not constitute a very special vulnerable group from all the information we gather from across the world. But one of your patients, Professor Walker, we need to says, hello, Dr. Walker from Cyprus. I owe my life to you, and I thought we should read it. Comes from Ahmed Barolu.
Yeah, I was going to close off.
Hello, Ahmed. Hello. Good to hear from him.
Katia is the last question, yes.
And the last question, how is the recommendation for a Thal major on combination therapy, L1 desferal, cardiac EF about 50% less and more, while the normal T2 star about 30? For A, it didn't finish.
Well, that ejection fraction is a little low. I'm not sure what age this questioner is. It'd be important to ensure that something else isn't happening, that things like diabetes, thyroid, and other endocrine issues are appropriately treated, because that mildly reduced ejection fraction doesn't appear to be explained on the basis of any iron, because with a T2 star of 30, it's likely that there's not much iron in the heart today. And there may have been in the past, of course. And we do see some people who don't make a perfect recovery in function after you remove the iron, particularly if they've had the iron in the heart for decades. So I would say very, very clear to continue with the chelation to maintain the T2 star both in the heart and the liver at acceptable, very high levels, that is, with no iron in either tissue. And then, people assume just because you're thalassemic, it all must be due to that. Well, unfortunately, thalassemic patients, like everybody else, may get other things, and they just need to be gently looked at and explored to make sure there's not another reason for this minor reduction in left ventricular ejection fraction.
Okay.
Thank you very much.
Thank you.
I think there's yeah. The last question from
there is one last one. Yeah. How much echo tissue Doppler is useful in thalassemia?
Very short answer, but it needs to be done. You need to have. I think it's much superior to left ventricular ejection fraction using the tissue annular, the DTI, mitral annular velocity, and looking at GLS increasingly. Again, in our hands from this Indian cohort, it's more sensitive than ejection fraction. And it will supplant it, but it's a long, slow job.
Okay.
Yeah, we have one more question from Laos.
I saw that, yeah.
Yeah, please, can you read, please? Thank you very much. Yeah.
Well, it's a very interesting question, which I can't answer. I hope our publication will go some way to encouraging the take-up, because what we did was to use local machines, old machines. We managed to teach the local technicians to do the right sequences, and then we analyzed them, and we're able to get very, very well, completely diagnostic scans in all but 1 or 2 patients within 12 minutes, which reduced the cost. So it's a question of other countries looking at what we've published and saying, okay, I want to do this too. There's absolutely nothing to stop people doing that. You know, it is out there. All of what is being done is in the public domain. So there's no excuse or reason, to be honest. I think if local patient groups, a bit like in India, that was India Thalassaemics, do patient camps, then trying to incorporate a rapid CMR into the protocol is what I'm going to emphasize in the publication that we're putting out at the moment.
Malcolm, can I ask you, can you define a little bit more what you mean by old machine? When does a machine suddenly become useful for T1 mapping?
Essentially, they need to, the machines themselves are usually okay, it's the software. And the software upgrades cost a lot of money. And so many institutions, both in the UK as well, we suffer from this as much as you guys, perhaps a little less, but the machines just keep on running. So the ones we were using were probably at least 7 to 10 years. The software was 7 to 10 years old, so old software. And the newer software that can do the T1 mapping is much more recent. It's 2 to 3 years.
So it's basically the cardiac module that it's the software that's incorporated into the machine. Okay.
What we have found is that particularly the old software modules that promise to do T2 star are not well executed and not well done at all. So that and this is one of the things that motivated me to go do what we did in India. We did take our physicists and they did put in our sequences into these old machines. It is software, it is well beyond my expertise, but essentially it's very important in how you set up the machine to do the appropriate sequences that will be able to generate those curves that are adequate to be able to curve fit and get a T2 star out of. But even the very old machines can do it. It's just a question of someone doing the appropriate software. And I say those software, I mean, those sequences are in the public domain. They're not secret.